to the Family Drug Court Learning Academy webinar, Responding to Domestic Violence in Family Drug Court. I would like to acknowledge that we did receive a lot of questions from all of you during the registration process. We tried to incorporate most of these questions into our presentation. So a little bit of background about the Family Drug Court Learning Academy. Launched in 2010, the Family Drug Court Learning Academy encompasses 4 learning stages or learning communities geared towards each developmental stage of your family drug court. The Learning Academy has had 23 webinar presentations, over 1,600 total attendees across 45 states, and you can access the materials and recordings of all of our previous Learning Academy webinars on our website at www.cffutures.org. Here you can see the title of each learning community and the topics within them. As you can see, each community is focused on the different developmental stages of your family drug court. However, no matter what stage of development you are in, you will find informative material in all the previous webinars. As I mentioned previously, you can access any of these webinars with live recording as well as all the material. Listening to your feedback from previous webinars, we heard many of you say that you'd like to hear more about what other family drug courts are doing in the field. A stronger emphasis on peer-to-peer linking and more discussion topics. As a result, the 5th Learning Academy series is the Knowledge Sharing Community, where we will highlight what other model family drug courts are doing around the country during each webinar. Today's webinar is the first of the Knowledge Sharing Community series, and domestic violence in family drug courts. So next, I would like to go ahead and introduce you to my colleague, Teresa Lemus, who will provide some opening remarks for today's webinar presentation.
Thank you, Alexis. My name is Teresa Lemus. What I'd like to do first is just talk a little bit about our presenters today. So today we have a panel of speakers that I think you will find very interesting and will be able to help you all start thinking, if you haven't already, about how to respond to domestic violence and the families who are involved with domestic violence in your family drug court. So we have presenters from kind of all over the country, and I know we have participants from all over the country. So I'll first introduce Larry Bennett. Dr. Bennett is an associate professor at the Jane Addams College School of Social Work at the University of Illinois at Chicago, where he received his PhD in 1990. Dr. Bennett is the author of articles and book chapters on substance abuse and domestic violence. He also is the co-author of the Evaluation of Services for Survivors of Domestic Violence and Assault. Dr. Bennett has served on the domestic violence advisory groups of several public agencies. He's been on the consensus panel on family violence of the U.S. Center for Substance Abuse Treatment, and he is a licensed clinical social worker in the state of Illinois. And what Dr. Bennett will be covering in the middle of this webinar today is really how to incorporate domestic violence screening, assessment, and interventions into our practice. And I know that many of the questions that came in about this webinar had to do with those issues exactly. So we look forward to that. The other 2 presenters come to us from, I lost my notes there. They come to us from the Santa Barbara County Child Welfare Services and the Family Drug Treatment Court. And that is Julie DeFranco, who has her master's in social work, and Julie Borba, who is a licensed addiction counselor, again, both from Santa Barbara County. And they're going to talk to us about how they have incorporated some of the principles and how they've incorporated domestic violence practice into their family treatment drug court. So we look forward to that. Our learning objectives for today are to understand the relationship between domestic violence, substance abuse, and why understanding this is so important for us in the field. I think we all understand that, or we wouldn't be here on the webinar. I think that we'll be getting into some of the first steps for screening methods and interventions and talk about strategies to respond to families with interpersonal violence. We want you to be thinking throughout this webinar today about, if you don't have someone from the domestic violence community on one of your committees for your family drug court, that's going to be one of the things we talk about today. So let me just get into our first section of the webinar. We're going to be talking today about really the first steps that either some of you have taken or you would like to take to help your family drug treatment court have an improved understanding of the issues and begin to develop or refine your FDC's response to domestic violence. One of the things we would like to promote today and have you really think about is having that no wrong door policy, whereby families can walk into any of our agencies, whether that be substance abuse treatment, child welfare, or in the family treatment drug court, and have us respond in a way that is collaborative and helps these families find the resources that they need. So responding to domestic violence in the context of a family drug court, why is this important? There's a number of reasons. I just want to talk about some of the work that's been done on this issue. In 2010, the Office of Juvenile Justice and Delinquency Prevention, referred to as OJJDP, contracted with the Center for Children and Family Futures to conduct a needs assessment of the family drug court field. Some of the issues that emerged from that needs assessment touched on several different issues, including the need for family drug courts to think about serving a broader audience or a broader part of the community. So really to look at the eligibility criteria for who was admitted into the family drug court and who, more importantly, was not taken into the family drug court. Said in a more sort of blunt way, stakeholders who responded to the needs assessment said, we really need to look at those families who need our help the most. Families involved in domestic violence and those who suffer from mental illness or serious mental illness were often screened out by FDCs, and this stakeholder group really wanted that to be looked at by our family drug courts. In a more recent needs assessment that was conducted by the National Center on Domestic Violence, Mental Health, and Trauma, that needs assessment really looked at the fact that domestic violence can have serious mental health consequences and may actually contribute to a substance use disorder. And the other thing that came out of that needs assessment, which I don't think is a surprise to many of us, is that our systems are frequently unprepared to respond to that complex set of needs. And so that was one of the things coming out of that needs assessment was, again, going back to that collaborative, we have to find a way to offer the no wrong door and help these families get the services they need so that they can feel safe and get further along in their recovery and the work that they're doing with their children in child welfare. So when we come across domestic violence in a family drug court, what do we know about this? Well, we know it happens. We know that there is a crossover population that ranges anywhere from 30 to 60%, meaning that we share the same families a lot of times. Going back to those needs assessments, we know that many family drug courts screen out those high-risk, high-need families that have domestic violence involvement, not because they don't want to help them, but because they feel inadequately prepared to address the safety needs of those families. And so we're hoping that, again, we take some steps today to get further, to get you more information to help you start incorporating these things into your family drug court. A few other things that I want to point out before we move on is that where domestic violence exists, a child is more likely to be neglected. That doesn't mean that's so 100% of the time, but research conducted and actually put out by the Children's Bureau through a Child and Family Service Review in September 2011 said that research of abused children suggests that there is a 30 to 60% overlap of child maltreatment and domestic violence. So again, going back to that crossover population. We know that parents with extensive criminal histories, inadequate housing, and have a greater risk for domestic violence can complete and be successful in family drug court. As a matter of fact, some studies that were done by some of our colleagues, Douglas Marlowe, who many of you know, Dr. Marlowe, and Dr. Shannon Carey, talked about recently in a research update on family drug courts that parents with these complex needs often are more likely to complete a family drug court than other families. So we're not going to present today that this is an easy path for family drug court teams to start taking on these issues, but we would again like to sort of set a baseline and have you take the first steps or refine those steps and share your work with others. Before I hand it off to a polling question, I just want to talk quickly about some resources. The Green Book, which was a publication released in 1999 by the National Council on Juvenile and Family Court Judges, formally entitled Effective Interventions in Domestic Violence and Child Maltreatment, linked domestic violence, child abuse, and neglect together, and, no surprise to most of us, promoted collaboration amongst child welfare systems, domestic violence advocates, and dependency courts. In that document, they underpin some concepts, which I won't go into all, but I'll just bullet a couple of them, were that child welfare agencies can best protect children by offering battered mothers appropriate services, which include helping them find appropriate protection, but also creating that common language between the child welfare system, domestic violence, substance abuse treatment, and the courts. Those of you who are already participating in a family drug court know that that is not an easy task, that really lays a foundation, that common language, for much of the work that you did in the beginning as you implemented your family drug court and continue to do as you refine your family drug court. But we know that it lays a foundation and it starts the development of relationships and the sharing of knowledge so that we have a better understanding of one another, the field that we come from, and how we can help these families as they reach out to us. I'd like to have this polling question that says domestic violence, advocacy, and services are included in assessment and case plans for our FDC. So please think about your family drug court and respond to this polling question. All right, so here's what you said to us. It looks like about 30% of you agree that domestic violence, advocacy, and services are included. 32% somewhat agree, so you've taken some steps. 10% no, and 30% say not sure, don't know. So that's terrific. Hopefully, as you finish this webinar today, for those of you who don't know or maybe haven't started this process, this will be a first step for you. So now I have the pleasure of transitioning the presentation over to Dr. Larry Bennett. He'll be talking to you more in depth about how to incorporate domestic violence screening and assessment into your family drug court. Dr. Bennett?
Hi, everybody, and greetings from the Windy City. Glad to be here and look forward to hearing some questions. I'm not a drug court guy. I'm more of a DV court guy, but I think that the reason I'm here today is to talk a little bit about what we know about the link between substance abuse behavior and intimate partner violence, and to talk about some issues about screening, which we've done a lot of work on here in Chicago, and then we'll see where we go from there. And I am also not able to advance my slides, so if somebody could give me the next slide. So it occurs to me that when we're sitting in an agency, a court-related agency or something like that, and talking about domestic violence, that there could be a number of different situations present. One is you might know that somebody has a domestic violence issue when they come to your family drug court because they've been sent there perhaps by a domestic violence court. We know in Chicago that our domestic violence court sends people to drug court when they think, in particular, if they think that the substance use disorder history is substantially a substantial part of the problem. They might send them over to the drug court. So others of you might be in drug court, and based on the case history and just your information that you have, you might know that the person has a domestic violence problem. But I bet you dimes to donuts that most of you do not know whether or not people coming to drug court have a domestic violence problem. Now, I was somewhat encouraged by the poll that was just taken. That's a lot more than what we're used to seeing, and if that in fact holds up, I'd be very encouraged about that. But I think that we have an issue with uncovering this issue of domestic violence. So these are numbers to sort of the epidemiology of the issue that you've all probably know or have some inkling into, regardless of whether we look at the domestic violence community and ask ourselves how many of these folks have substance use disorders or issues, or whether we look at the substance abuse treatment community and ask ourselves how many of these people are involved in domestic violence. We're going to get pretty large numbers, particularly when we look at the substance abuse treatment community and look at women, where the numbers are astronomically high. Approximately 80% on average of women in substance abuse treatment are currently victims or have been victims of domestic violence or sexual assault at some point in their life. It's a very high number. Now, the fact of the matter is we don't know, we don't have good data on how many people coming into drug court have domestic violence because the research just hasn't been done. One thing we know for sure is that regardless of which of the problem-solving courts that people are involved with, prostitution court, mental health court, drug court, DV court, whatever, it seems like most of the people coming into those courts have most of the problems that the other courts address. In other words, we have these courts that are set up to deal with specific issues, but the people coming into those courts oftentimes have multiple issues. I'm not telling you anything you don't know, but we don't really have good data on how many people coming into the court are domestically violent. So one thing we can do as kind of a proxy is we can look to substance abuse treatment agencies, and we've done this a lot, and ask ourselves how many people in these agencies have domestic violence as issues, and then we can take that as kind of a bottom line because we know domestic violence is always going to be a lot higher among people who find themselves into court compared to people who just find themselves in substance abuse treatment. So we're pretty sure that the number half is a good number. Half of the people that you're seeing that you're involved with in your family drug court are the victims of domestic violence or perpetrators of domestic violence or both. Even though these numbers are substantial and it would convince everybody that substance abuse and domestic violence need to be attended to together, the fact of the matter is it's not quite as simple as all that. The vast majority of men and women are not drinking or drugging when they batter. The vast majority of people who are heavy drinkers never batter. And if you want to know what a heavy drinker is, we have a technical definition, and that's 5 or more drinks per drinking episode. So I'll be silent here for a short time while you do your own personal calculus on that. But the vast majority of them don't batter. And as a matter of fact, the relationship that we see between substance abuse and domestic violence really only fits a subgroup of people. Now, who that subgroup is what we're going to be talking about a little bit. And Holly Johnson up in Canada did a great study where she looked at substance abuse and domestic violence and found that, just like all the other studies, enormously high rates of co-occurrence were found. But when she entered male-dominant attitudes into the equation, the relationship between substance abuse and domestic violence lessened substantially. And what that means is we can't just pay attention to substance abuse when it comes to dealing with domestic violence. We also have to pay attention to attitudes, particularly attitudes towards gender. Now, normally I spend a lot of time talking about this because it's my experience over these many years of doing this that people have a fairly simple idea about how substance abuse and domestic violence works, and the vast majority of you will believe, as the vast majority of everybody believes, that what happens is that alcohol or drugs somehow disinhibit the brain, who is responsible for keeping us from being violent, making us civilized. It sort of unhooks that thing and allows us to become more animalistic and more violent and do all sorts of things like that. And we call this disinhibition. And that's an old-time notion. Nobody really believes that anymore because there's really no part of the brain that's responsible for doing that. And what we've done instead is we've understand that this is a cognitive process. The effects of alcohol and drugs is not on the brain, it's on the thinking process. And it alters people's ability to solve problems, to accurately perceive the situation, to accurately estimate the future consequences of their behavior, and so forth. And of course, you don't need alcohol and drugs to do that. You can do that quite nicely on your own without getting high or stoned. And so that's a little bit better understanding of the effects, because let's admit it, if alcohol and drugs were a direct cause of domestic violence, we could just get people to be clean and sober, and that would take care of that pesky domestic violence problem once and for all. But, you know, domestic violence batterers programs are just chock full of 12-steppers, so we know that that doesn't work. We know that it takes a whole lot more than just getting clean and sober to deal with domestic violence, and therefore disinhibition is only part of the issue. The other part of the issue are, and I'll explain, I always talk about these as lenses. All of them have a good thing to say and a good contribution to make when it comes to screening and assessing people for co-occurring domestic violence and substance abuse, and it makes sense to talk about them. The second lens is the effect of co-occurring conditions, particularly attachment issues due to trauma in childhood and subsequent conduct disorder and subsequent antisocial personalities as adults. Now what happens is people have these sort of early loaded problems, and they develop both substance abuse behavior and domestic violence out of those issues. And so the apparent connection between substance abuse and domestic violence may seem like one causes the other, but in fact, that co-occurring condition causes both of them. So that's the second explanation. The third explanation is beliefs about the effects of alcohol and drugs on behavior. Now, I don't know about you, but I know for a fact that when I use alcohol, I'm a better dancer and I'm better looking. And my wife insists that's not the case, but I've had the direct experience of knowing that that's the case. And so you can't really convince me otherwise. A lot of people have beliefs that when they get stoned or high, that something is going to happen. I've interviewed a lot of people, and they have said, well, you know, these are victims of domestic violence. He's fine when he's, you know, drinking Miller Genuine Draft, but then when he switches to Jack Daniels, all hell breaks loose. You know, now Jack Daniels and Miller Genuine Draft are the exact same drug, and so this is a belief system that somebody has. And of course, if I'm a batterer and I don't want to waste my time going to jail and to get somebody to do what I want to do, if she's not acting right, I'm just going to, you know, go pull out the jack and let her see me do that, and that'll take care of that situation pretty quick. So another issue then, another lens that makes this an interesting issue is motivation for power. I wish I had time to talk about this because this is very important, but it tends to apply only to men. It turns out that alcohol and drugs tends to increase our desire to have either power over other people or our power to make things happen. And a lot of research has been done to support that. So to the extent that alcohol and drugs might be involved in enhancing our drive for power, then that would also be an explanation. The situation itself is an important explanation for the relationship between substance abuse and domestic violence. Well over half of the people who are victims of domestic violence and perpetrators say that it wasn't the alcohol and drugs the issue, it was her standing in the way when I was trying to get to my drugs that were the issue. I wanted the cocaine, she wouldn't let me have the cocaine, and so I had to take matters into my own hands. That's a situation causing domestic violence and substance abuse to be related, but it's not the actual drug itself that's doing it. I hope you can hear the difference. Earlier trauma I've talked a little bit about. I won't say anything else about that, but I want to just wind up with the notion of excuse making. It used to be that, well, if I want to get drunk and go take a whiz in the A&P parking lot, I feel perfectly comfortable doing that, and then when I get hauled into jail for something, I could say, well, look, you know, I'm not that kind of guy. That's not the kind of person I am. That was the drug talking. I mean, I would never say that to the judge. Of course, I would say that was the alcohol talking. That's not me. That's the alcohol. So using alcohol and drugs as excuses for behavior is a time-honored way of doing things. Now, it turns out the court doesn't pay much attention to those excuses anymore, except when it's the domestic violence victim who is using alcohol and drugs, and then the court pays very close attention to it and oftentimes doesn't take her seriously when she's seeking an order of protection or things like that. So anyway, the bottom line is all of these possible explanations can explain the relationship between substance abuse and domestic violence, but we can't assume that any of them work all the time. Most of all, we can't assume that just getting someone clean and sober or in recovery is going to result in a reduction of domestic violence. Why? Because we have all of these other traumas, all these other motivations, all these other beliefs, all these other co-occurring conditions, all working on this and making the alcohol and drugs in some ways not necessary. Now, a lot of the questions that people gave when we set up the workshop and when you registered had to do with how do you screen for domestic violence, and I want to talk about that. But I need to say that a lot of the domestic violence that goes on is perfectly legal. In fact, I'll just say that the vast amount of domestic violence that goes on is perfectly legal. If you wanted to ask some questions that would illustrate domestic violence, I've got 10 of them here that you can ask. Now, this assumes that the person is and I've written this to be kind of gender-free, but this is called the WEB, Women's Experience of Battering. This is a regular instrument that's used to screen for domestic violence. But it never asks the questions about pushing, kicking, punching, slapping, shooting, all of those things that are illegal, and they would be illegal regardless of who you did it to. Again, these ask about how people feel as a result of living in a home in which domestic violence is occurring. And it's as if you're asking potential perpetrator of domestic violence to ask themselves these questions. Do the people in your house ever feel ashamed of the things that you do to them? Do they seem to feel programmed to react in a certain way? Do they seem to have to walk on eggs around you? Do they seem to be owned or controlled by you? This is something that even someone who was in denial that they were a batterer might be able to understand that people treat them a little bit differently because of the way that they are, not because of the crimes that they've committed, but because of the way they make people feel. So part of what we have to do when we do assess particularly victims of domestic violence is we have to go outside of what the law, next slide please, we have to go outside of what the law recommends and recognizes as domestic violence. The law only recognizes episodic physical situations as domestic violence, and these would be situations that would be, this would be domestic violence whether it happened to your partner or to your roommate. And so these are fairly easily described: punching, kicking, slapping, anything that's physical, assault, battery, charges like that would stand up anywhere. These are the things that the law recognizes as domestic violence. Next slide, please. However, when we talk to victims of domestic violence, we find a very different situation. It turns out that these episodic slapping, kicking, punching things are certainly a matter of concern. They're very serious, they're very physical, they hurt and scare somebody, but it's the daily grind of having to live in a situation where they're really not sure what's going to happen next that is weighing on them. And so the unseen part of domestic violence also has to be assessed, not just the seen part or the part that the court or the law enforcement regards as illegal behavior. It's the perfectly legal behavior that covers 90% of domestic violence. But we also have to screen for that. Why? Because if people don't stop battering, and if they are unable to get out of situations so that they're no longer victims of domestic violence, they're not going to recover from their substance use disorder. It's just that simple. Now, I put these typologies in here because people sort of are getting the drift that there are really different kinds of batterers. And when I go to domestic violence court, I hear judges and prosecutors and people talking about coercive control, and intimate terrorism. So this is something that the courts are becoming aware of. How useful it is really not clear, but the courts seem to be very involved in learning this lingo, so it makes sense to talk about it. This came out of the big conflict that's been going on in domestic violence field for the past 20 years around women being as violent as men, and you've probably heard that phrase. In fact, many of you believe that. And so it turns out that most of the big population studies, that is when we just take a random sample of people out there in America, most of those studies have found a roughly equivalent rate of male to female and female to male domestic violence. Of course, we don't know very much about male to male intimate partner violence or female to female intimate partner violence because we can't do these kind of random samples with that particular population. So this is referring only to heterosexual domestic violence. But in general, all these big population studies show the same rate of domestic violence in men and women. But when you look at, as the Canadian filmmaker Valley said, you know, if you want to find out about gender and domestic violence, you know, just go look at who's in the hospital, who's in the shelter, and who's in the grave, and you're going to find out that it's mostly women. And that's true. If you're talking about injury, domestic violence that involves injury as opposed to just pushing and shoving, or domestic violence that includes trying to control the behavior of the other person, then you're really talking primarily about men abusing women. So Johnson came up with this typology that recognized this, the idea that we have different kinds of domestic violence. One he called intimate terrorism, and this is almost always men abusing women. It tends to be very severe and more frequent, and when the damage is done, it's primarily going to be through intimate terrorism. Although the second type is not damage-free, but in this type, which he called situational couple violence, this is kind of like, the notion here is that I don't like something you did, you don't like what I did, I like you even less, you like me even less, and we eventually evolve into getting into a little pushing match, and then we go to our separate corners. Well, that was illegal domestic violence that occurred, but it certainly wasn't the same kind of domestic violence as the person where you're trying to control their behavior and threaten them and threaten to kill them and not let them leave the house, etc. It was more of a mutual conflict sort of situation, and this tends to be men and women doing this. The third type is almost always women, and that's self-defense. And the fourth type I'm not even going to talk about because it really doesn't happen very much. Next slide, please. When we talk about specific characteristics of batterers, we do have a typology that we use, the trifold typology of normal, family-only batterers, dysphoric borderline batterers, and generally violent batterers. Next slide, please. Half of the people coming to batterers programs, half the people that you're going to see in court are going to be completely normal. You're probably not going to see them if you're in drug court because they don't have substance abuse problems. And they don't have mental problems either. They're really indistinguishable from men in the general population, and this typology does refer only to men. And this is, like I say, half the people that we're going to be seeing in the batterer intervention program. The other half of the people that we see in court and in batterer intervention programs are far more concerning to us. The first type is called unstable batterers. These are men who are kind of emotionally unstable. In the olden days, we used to talk about a cycle of violence where there would be a period of tension, and then there would be an explosion where domestic violence occurred, and then there would be a period of time when there would be some sort of honeymoon period and people would get along, and then the whole thing would start over again, tension, explosion, honeymoon, tension, explosion, honeymoon, and so forth. And we don't really use that anymore because a lot of battered women are saying, hey, when do we get to that honeymoon part? For me, it's just tension, explode, tension, explode. And so it doesn't really describe domestic violence very well, but what it really does describe is what's going on in the head of a certain subtype of batterer where their relationship to their partner determines how they're going to feel. If she says, oh, we should date more, all we want to, you just want to have sex, we don't ever go out, we don't talk, you know, we don't share much, we're ships passing in the night, the batterer then feels overwhelmed as if they're being pressured, and they back away. Well, after a while, the partner gets tired of that and decides that she's going to have her own life and she's going to go out and do things that she wants, at which point the guy feels abandoned and comes after her and tends to cycle back and forth between this thing of being abandoned and being overwhelmed. And this is the kind of instability that we're talking about in this sort of person. Their mood kind of depends on their relationship. They don't seem to have a mood independent of that. And in order to deal with this situation, a lot of, and this is about 25 to 40% of the people that we see in court, a lot of people use alcohol and drugs to regulate their mood, or they use some other form of neurotransmitter manipulation like compulsive sex or gambling or risk-taking, something to sort of modify their mood because their female partner, who's usually in charge of their mood, is not working for them. So unless these people get help in addition to whatever the domestic violence program or the court is doing, unless they get special help for their co-occurring issues, they're not going to be successful in court, they're not going to be successful in domestic violence, they're not going to be successful in life. Next slide, please. And the third type, while the dysphoric batterer may use alcohol and drugs to regulate their mood, generally violent batterers use alcohol and drugs to have a mood. These are very stable people, unfortunately, and they tend not to change their mood very much. They may lack empathy. This is about 10 to 20% on average of the people we see. These are very dangerous people. They're far more likely to do serious injury to their victim. Their use of alcohol and drugs is to relieve boredom as opposed to regulating mood, and so these are people that all of the court interventions and all of the community interventions that we have, so including substance abuse treatment, so far doesn't work. So I gave you another typology, which is a typology of women, and I'm not going to talk about this other than to say this, that women are arrested for domestic violence, and the vast majority of women arrested for domestic violence are also themselves the victims of domestic violence. So the one thing you do not want to do is to send a woman, it comes through the court, to a Batterers program. You don't want to do that. You want to send them instead to a domestic violence shelter or a victim service agency that has a program for women arrested for domestic violence. It's a very different program than the typical Batterers program, and it acknowledges their trauma and their victimization. I think I'm going to just briefly say that two questions that we often want to have answered when we're thinking about domestic violence is, are there places that don't have domestic violence? Are there societies in which domestic violence occurs far less than it occurs in our society? And the answer to that is yes, there are. And the second question is, are there characteristics of men in particular who batter compared to men who don't batter? And yes, there are. In terms of the societal levels, only about 15% of societies in the big anthropological study that was done to look at this have no domestic violence, and about 85% have domestic violence. Those societies which have domestic violence have certain characteristics that differentiate them from societies which they don't. And the biggest one is that in a society with domestic violence, you can actually get away with it. Only 4 out of every 1,000 episodes of domestic violence ever get any kind of sanction in the United States. Why? Because we have a lot of the characteristics, lots of guns. We're the Mount Sinai of gun worship in the world, and we have lots of guns. We have lots of animals used for sports, horses, dogs. We have a lot of male military glory. We have all the characteristics that anthropologists tell us are associated with societies in which there are lots of domestic violence, and we do have lots of domestic violence. And as far as the people who are more likely, have greater risk to be victims of domestic violence or perpetrators of domestic violence, those people who have violence in their family of origin, those people who are poor, and those people who are active substance abusers, at least by the perpetrator, are more likely to have those characteristics. I want to spend the rest of my time talking about screening. The place where I am at, the Great Lakes Addictions Technology Transfer Center, has developed for SAMHSA a screening protocol for domestic violence. This is for substance abuse counselors. It's not necessarily for courts or primary care healthcare entities, but it could be, as you all know, the Affordable Care Act is going to make domestic violence front and center, and substance abuse agencies are going to have to screen for domestic violence if they want to continue to function as a healthcare entity. And if you screen for domestic violence, you have to do something about it if the screen is positive. So here is a screening protocol that we would like to develop, push on people. We would like everybody to ask a 3-item screen. It doesn't actually matter which one. We've picked one that is very good because it has some of the major characteristics that we need to ask in a screen. It does ask for the punching, kicking, slapping question, but it also has 2 other questions, but I'll tell you about what those are in just a second. But if the person screens positive, then we go on to the next stage. However, if they screen negative, that is, they're not the victim of domestic violence, we still believe the agencies need to give everyone an educational pamphlet on domestic violence that includes the name and a contact information of the local domestic violence agency, some basic facts about domestic violence, just in case. So if the person does screen positive for domestic violence, and here are the screening questions. Let me tell you why I like these questions. First of all, there's the slap count question that everybody is very familiar with. You need to ask whether people have been hit, kicked, punched, or otherwise hurt, or threatened. It's not just laying hands on that is domestic violence, but it's the threatening of the violence that has to be asked as well. So that's a question everybody understands. And when we train people to do these screening procedures, we like them to do it conversationally. The last thing you want to do is sit down and read items off a list. You need to learn these questions and learn to do them conversationally. Now, so that's one question. All the stuff that everybody thinks should be in a domestic violence screening tool is in the first question. The other 2 have to do with fear. The most important question you can ask someone if you're trying to screen them for domestic violence is, are you afraid? Are you afraid? Are you afraid to go home? How does it feel to be in the house? Some of the questions that I talked about earlier. The third question might seem as kind of a surprise, but because people have children with previous partners, and because they may be in more than one relationship, frankly, we need to also ask, is there anybody else in addition to your partner? Is there anybody else that you're afraid of, such as an ex or something like that? So anyway, these are the screening questions that we think can be asked. Now, people might say, well, that's only 3 questions. That's not a very big assessment. Well, no, it's not. It's not a big assessment. These are really the only 3 questions that you need. Because all we're doing is screening. When you screen, you don't need a master's degree in counseling to screen. You can be a secretary, you can be a janitor, and screen just as well as somebody who's got professional credentials. The idea of a screen is you find out whether someone needs additional assessment. Now, the assessment may need to be done by someone with some professional background because you need to understand the dynamics and all of that kind of stuff. But anyway, if a person screens positive, you don't do screening, first of all, necessarily unless you're ready to do something about it. And what we recommend that people do about it, if they get a positive screen, we recommend 3 interventions. One is an educational intervention. You give them a pamphlet that discusses DV, and you discuss that with them. The second thing is you begin developing a safety plan. Now, you're not going to spend, in a screening interview, you're not going to spend hours doing this. You just begin the plan. And we've got plenty of examples of safety plans, completed safety plans, and things like that. If you want to email me, feel free to do that, and I'll give you the whole shebang. The third intervention is actually an assessment, and that we consider trauma assessment to be an intervention. When you're dealing with someone who's in crisis and traumatized, talking about that trauma, which we call exposure, exposing that trauma, is actually an intervention. And we think that 2 kinds of trauma needs to be exposed. One is childhood trauma that you would get through the ACE questions and things like that. And we have another questionnaire that is more focused on domestic violence. First, worst, last, and typical. What was the first time you were abused? What was the worst episode of abuse you ever experienced? What was the last time that you were abused? And what is a typical episode look like? And And incidentally, ACE stands for Adverse Childhood Experiences. I didn't put those questions up here. I assume most of you would know that, since that would be more in your field. So, and now after a person has a screen and you've done some very brief interventions, you need to make some kind of a referral. Now, we call this a robust referral. Some people call it a warm referral. Here's the way you don't refer someone. You don't say, well, here's the name of your domestic violence agency, you should give them a call. That's how you don't do it. How you do it in a robust referral or a warm referral is you walk them there. You take them there. You call the agency and you grease the slide for them. Now, in order to do that, you need to have a relationship with that agency. So some of this is out of your individual practitioner control, in the sense that your agency has to work with the domestic violence agency to build a relationship, to have memoranda of understanding so that we can deal with all the confidentiality issues that these different fields have, and so forth. So we have to have this in advance. A robust referral means that this has already been set up and that you're going to now walk that person either to a program in your own shop or to a program in the community, or if there's no program anywhere, and in rural communities that is likely that you might be an hour away from a domestic violence program and you don't have one announced. In that situation, there's some special things that we need to do we don't have time to talk about here today. I use these slides that actually come from a guy named Miller in Missouri, in part because I don't deal with drug courts, and so I need to you know, talk about some of the things that drug courts might do that are different than substance abuse agencies might do. I don't know that I'm going to go through all of these because I'm looking at my time and I'm running out of time. But I think I'll highlight the things that I think are most important. The most important is to have, as you know from the survey that you took, is that your treatment team have somebody. You need to hold the batterer accountable, and you need to keep the victim safe. Those are the two things that we need to do. Now, BIP stands for Batter Intervention Program. And he says here, if possible, the treatment team should make a referral to a Batter Intervention Program. Well, I'm kind of leery about that because Batter programs don't work really well with sort of informal referrals. They work really well when a judge says, get you to a Batterers program, and writes that in an order. In fact, people who self-refer to Batterers programs, so-called voluntary referrals, which in the field we call them wife referrals, because we don't really think anybody goes voluntarily to a Batterers program. We think something else is going on. People who self-refer to Batterers programs tend to reoffend at a significantly higher rate, and they tend to drop out at a significantly higher rate. So anything that you can do to get the court to make that happen is going to be a good thing. Bottom line is you want to have both victim advocates and Batterer intervention programs represented in your FDC. And I think that this is more discussion of the same kind of situation. And they're talking here about the importance of looking at victim safety and batterer accountability. Now, you might have the victim in your FDC. She's the one who's in drug court. And if that's the case, she has someone, probably has someone, at least one person in her life, who is her batterer. And that person you have no control over. And you have to figure out how you're going to make her safe when you have no control over this other guy. On the other hand, you may have a batterer in your drug court, at which point you have a victim out there in the community who is unsafe, and you have to figure out how to deal with that situation. The way out of both of those situations is to get support and help from the domestic violence community, and they should be on your team. They can grease that slide and make those things happen a lot easier than what you can do. Again, when we refer people to domestic violence agencies, either Batterers programs or victim service agencies, we want a robust referral. We want a warm handoff. We don't want just telling people to go places. We want this to be a seamless kind of situation. In order to do this, you have to have some kind of protocol in place. You have to have policies in place so that we're all on the same page. Again, I'm emphasizing the necessity of having a lot of this stuff front-loaded, a lot of these policies already in place, a lot of this community organizing already done, a lot of this reaching out to agencies has already happened, so that when you're doing these warm referrals, these robust referrals, you're trying to get people safe, you're trying to hold them accountable, you're doing that to known entities where there's a flow back and forth and it goes fast and easy. And if they don't show up or they drop out or something like that, guess what? You know that immediately. You don't have to wait for their next appearance to find that out. A lot of work has gone into this field to try and look at the relationship between domestic violence and substance abuse, beginning with TIP 25 in the mid-1990s out of SAMHSA. And that's a pretty good manual. The Illinois people decided to write their own because they didn't like the SAMHSA manual as much because it tended to emphasize batterers less as criminal behavior and more as people with attachment disorders. And that didn't settle with the people in Illinois, and so they wrote their own manual. And incidentally, these are all up here because they're available, downloadable for free. And if that's not the case, I'll tell you. The third one, which I highly recommend, is out of SAMHSA. Again, it's they did a big study years ago. Most of you probably heard about it. The Trauma-Informed Services for Women with Co-Occurring Substance Abuse and Mental Disorders and are Victims of Violence. Big name, important study. It acknowledges that women in substance abuse treatment usually have co-occurring issues, and unless they're dealt with, they can't get clean and sober, and the co-occurring issues are just going to get worse. And so all of the manuals and material from that big study, which really is a very hands-on thing, it involved 14 different centers throughout the United States, some of which are in California, is downloadable as well, and I highly recommend that. And I think I have about 5 minutes. Iowa has done an integrated services project. Now Georgia, which might be the most interesting thing for some of you, this is actually, you're going to have to call Georgia and get them to send this to you. It's not publicly available because domestic violence is handled by the Department of Corrections in Georgia. And of course, the Department of Corrections always have lots of policies and things like that. And one of their policies is we ain't giving this out for nothing. But it's still a good manual because it's full of detailed information, lots of screening tools, lots of sort of linkage agreements between substance abuse agencies and domestic violence agencies and the court. A lot of the sort of detail work, the heavy lifting has been done already down in Georgia. And so I recommend that, and you can go to that website and sort of figure, if you need trouble with that, getting that manual, contact me. And then finally, there is a couple of, there's lots of assessment tools, a whole ton of them. The Center for Disease Control published this about 6 or 7 years ago. And a lot of them are what I would call researchy tools, and a lot of things that are good for research are horrible for clinical work, and so you need to sort of differentiate that. This is one of the best manuals there is. This is the Alaska manual. This is really great for women who have co-occurring substance use disorder. It's really good. First of all, Patty Bland did it, and Patty Bland does really great work. And secondly, it has a lot of sort of hands-on stuff that a lot of us tend to gloss over, thinking that people know this, but in fact, most of us don't know it. And so they just made a uber manual, big thick thing. And you can't, I don't think you can download this, but I think Alaska will give this to you if you write them. Oh, and there I am. So I think that I'm out of time, and we'll look forward to what my co-presenters have to say. Thank you.
Thank you, Larry. I think we've got a transition here to the Santa Barbara County Family Treatment Drug Court. So I'm going to introduce Julie DeFranco and Julie Borba, who will both be presenting in this section. Julie?
Hi, Teresa, and hello, everyone. I appreciate the opportunity to be here today to reflect on the experiences and lessons learned here in Santa Barbara and share our thoughts on moving forward from a child welfare perspective. So I'd like to first start with just giving you a little bit of information about our county for those of you that are unfamiliar. As you can see, Santa Barbara has a fairly large geographic spread, and we're also, in addition to being fairly spread out, we're very economically diverse, as well as culturally. And we have 3 distinct regions: Santa Barbara, Lompoc, and in Santa Maria being our northern areas and our rural Cuyama. Santa Barbara is the most affluent region. However, the greatest areas of need are in northern sections of Santa Maria and Lompoc. And it's for this reason that we decided to focus our program on serving Santa Maria and Lompoc. So this slide outlines our program goals. And rather than reading through these in their entirety, I'll just say that the foundation of our program is built on providing early and rapid intervention, culturally competent, gender-responsive, and trauma-sensitive services, with our goal of strengthening families, reducing recidivism, and decreasing time frames to family reunification and permanence. We are also very committed to reducing the amount of time our children spend in out-of-home care. In terms of the background of our program, we were actually able to establish our FDTC program in 2009 without any additional funding. And one of the great strengths of our program has been our collaborative partnerships, which enabled us to actually build our program. We developed our program out of a recognition that there was a great need for a more concentrated collaborative response to parental substance abuse and drug-exposed children. Under CAM, fortunately, we've been able to expand our program so that we're serving a larger population and really develop our program in terms of trauma-informed services. As I mentioned, one of the tenets of our program is trauma-informed treatment, and we recognize that of our families who are struggling with alcohol and drugs issues, there's almost always an underlying trauma or mental health issue, and efforts to engage these families and provide effective services without first attending to those traumas, we recognize as being somewhat ineffective. So we're attending to the trauma of our children, but also of the parents. So with that said, our goal is to stay focused on being aware of assessing for, responding to the needs of those traumas, including DV, and also really paying attention to the behavioral responses of the families and how that translates to treatment, to engagement, success, and healing, as we recognize that without this focus, there are really high risks to treatment failure. In addition to all of our providers on our FDTC team attending a seeking safety training, we also provide clinical supervision for our line staff to support them in addressing issues of secondary trauma so that they are better prepared and present in supporting our clients. I think that old adage, you can't give away that which you don't have, is very true, particularly around the complex and traumatic needs of our clients and those serving them. This next slide outlines some characteristics of the parents in our program. As you can see, we're serving a large Hispanic Latina population, and with a mean age of about 32 years old, and not surprising probably to many of you, most are presenting with polysubstance abuse issues. Our children's characteristics are in line with what we're seeing in our child welfare population as well, in that we're serving approximately 62% of children 0 to 5 with a mean age of 7 years old, and interestingly, a large number of male children. In terms of domestic violence in Santa Barbara County, we have a strong working relationship with our district attorney and our victim witness program, and they were able to provide some information. And so as this slide describes, in 2012 there were 4,000 new victims of crimes in Santa Barbara County, and notably 35% of those were DV related. So this really underscores that the incidence of domestic violence in our county is very present in crime and child safety issues, which highlights our need to be responding as effectively as we can to support these children and families. In our program, we have not been tracking, which is an area of opportunity in an empirical way, the number of cases that have an element of DV. Our estimation is that at least a quarter of our families are presenting at some point with an element of domestic violence. And there again, one of the challenges that we face, and I think Larry did a good job talking about this in terms of screening and really getting to these critical issues of interpartner violence and domestic violence early on, what we found is that unless these issues are present at jurisdiction and disposition, without some intentional focus, we may not be aware of them until much later. Our victim witness program is a great asset through the DA in that we can provide current services to families, but also in the future to support a continuum of care beyond the child welfare case, so that if a family presents with needs once we're gone, they know where to go and they already have that in line and set up as a resource. And so our program, I don't know if it's unique, and it might be something you want to look into in your counties and states. We're able to open victim witness services on a substantiated child welfare case, regardless of whether or not we have a police report. And that really eliminates a lot of barriers to accessing services through victim witness. Additionally, what we found is that if, for example, there is a treatment that is not covered by Medi-Cal, oftentimes our victim witness program can actually pick up that tab, which is very useful. So there again, it might be something worth looking into. In terms of our screening protocol, there again, in the interest of time, I'm not going to go through all of these or read them verbatim. Many of you are likely familiar with these tools. And I will, just want to be transparent here that none of these are specifically dedicated to interpartner violence screenings or DV, but several touch on these issues throughout the screening tools in the continuum of case assessment. So what this highlights for us is the importance of a close coordination with our service providers to ensure that if we're not capturing some of these disclosures and issues at the front end, that we're very rapidly and as timely as possible receiving that information and moving into action to make sure we're incorporating that trauma report into their treatment as well as their case plan. I thought it might be interesting to share some feedback from the ASI screening, as it appears to support the importance of obtaining comprehensive trauma histories, and also what Larry highlighted in terms of the need to screen beyond criminal, typical criminal definitions of DV. So in looking at these responses, although we do not necessarily see that there are large reports of DV trauma in the past 30 days, nearly 70% report conflicts with their partners in their lifetime, and a large number report histories of emotional abuse, physical abuse, and sexual abuse in their lifetime. This next slide is particularly noteworthy in the disparity between the clients that are describing that they are not at all bothered by family problems, but report treatment for family problems as extremely important. And so our thought is that this may underscore our thinking that clients are not often recognizing the impact of their earlier traumas on their current functioning and the importance of future treatment. So this slide describes our referral protocol, and I think what I'll do is just highlight and echo what Teresa said earlier on, in that our family drug program has not been immune to some of the challenges and difficulties in screening and not wanting to screen out those with the highest needs with regard to mental health issues and serious domestic violence but also wanting to be sensitive to accepting clients who are best prepared to benefit from our program and essentially not setting them up for failure. So there is opportunity for growth in that area. And interestingly, although our screening protocol requires our participants to not have engaged in serious DV, we actually have not had to screen out cases of domestic violence. But what we recognize is that there's an opportunity for us to look more closely in our protocol at what that definition might be, and so that that can help guide our practice in the future. Our participation protocol really underscores the importance of early engagement and that our participants are ready and willing to engage quickly and make the most of the program and services offered. And so one of the challenges, as I'm sure you're all aware, with family drug courts is that we're dealing with very complex needs of children and families, and we're also trying to mitigate those within mandatory timeframes. And so the early engagement piece is very important. In terms of strengths that we've identified, each area highlights the importance of that engagement between the client, department, and our treatment partners to develop a strong and reciprocal working relationship so that we are best prepared to support families in healing, safety, and meeting their court-ordered cases. Moving forward, and in summary, as mentioned throughout the previous slides, we recognize that each of these areas are among opportunities for improvement in better assessing and responding to our families. And we really appreciate Larry's suggestions, and we're looking to include the brief screening in the context of our social history for the purpose of our dispositional reports, and also in providing a pamphlet to the family, because I think that would be very useful. So with that said, it's my pleasure to turn the presentation over to Julie Borba of Turning Point, who will be sharing her work in collaboration with our department on the Seeking Safety program.
Thank you, Julie. Good afternoon, everybody. I feel really honored to be a part of this presentation today. Just a little bit of my background. I've been really fortunate to gain education and experience working with domestic violence victims in Santa Barbara County. As a certified addictions treatment counselor, I've been working with Good Samaritan services in their detox and perinatal treatment programs for a combination of 6 years. Currently, I'm working in Good Samaritan's perinatal program, which is called Turning Point. We serve pregnant and parenting women. Some of the referrals are from criminal justice. We have self-referrals. And we also work with the County Child Welfare Service, and we serve the clients in the Family Drug Treatment Court that Julie DeFranco was just speaking on. A little bit of background. Thank you. A little bit of background on Good Samaritan Services. We have a contract with Child Welfare Services, and we receive referrals from Family Drug Treatment Court, as I mentioned. Referrals for residential, outpatient, and detox services. Good Samaritan Services has been in collaboration with the juvenile courts for many years. Good Samaritan initially began as a homeless shelter in 1989 and has expanded to provide services in 2 local communities, which include detox, perinatal, residential, outpatient treatment, homeless and family shelters, clean and sober homes for both males and females, and several other programs to help our troubled population. So within our treatment programs, including the perinatal programs, we provide the Seeking Safety treatment. A little bit of information on the Seeking Safety treatment. Seeking Safety is one of the first treatments for PTSD and substance abuse with published outcome results. It provides an adaptation of cognitive behavioral therapy to a population of people who have a history of trauma and substance abuse. The title of the intervention expresses the basic philosophy of treatment, which is when a person has both active substance use and PTSD, the most critical urgent need is first to establish safety. Integrating treatment for trauma and substance abuse means helping clients learn what the two disorders are, like why they occur, how to explore their interrelationship in the present, and understanding the course of these disorders in their recovery. A few other things they learn to do is to increase self-compassion by viewing substance use as an attempt to cope with the pain of trauma, and also they learn they learn safe coping skills to use for both disorders. Seeking Safety is a present-focused therapy to help people attain safety from PTSD and substance abuse. So it doesn't go into therapist's work. Like I said, it's a present-focused therapy. The treatment is evidence-based, and it's available as a book. The book contains both client handouts and guidance for clinicians. Contact information for Seeking Safety will be at the end of my presentation. Regarding Seeking Safety, it is the only psychotherapy model for co-occurring PTSD and substance abuse this far that has enough studies to be classified as effective. The treatment was designed for flexible use and can be conducted in a group or individual format. It can also be used for men, women, and mixed gender. All topics or fewer topics can be used, and it can be facilitated in a variety of settings like outpatient, inpatient, or residential. A little bit on the last slide, the Seeking Safety treatment can be used with clients who have a trauma history but do not meet criteria for PTSD. And that's where I think it benefits victims of domestic violence. A portion of the mothers served by the Family Drug Treatment Court suffer from PTSD or have histories of trauma related to violence. Okay, now on to the slide that you see right now, which is the Seeking Safety group structure. This will give you an idea a little bit about how each Seeking Safety session is conducted. So first it starts with a verbal check-in. Group members here share their feelings, coping skills that they used within the last week, and any substance use or unsafe behavior is reported in the check-in. Homework from the previous session for a commitment done in that session, and also if they had any contact with any community resources is also self-reported. The check-in is followed by the start of the core of the group, and it starts with reading a quotation out loud. Each member then explores their personal meaning of the quotation. Each quotation is linked to the session topic and is very inspirational. Moving on to the session content, the handouts of the session topic are given to each group member. The handouts can be read as a group or individually. A group discussion and questions on the handouts follow. And after the topic is explored, a verbal checkout ends the session. Here in the verbal checkout, members share what they got out of the session and any problems they may have had with it. They also make a new commitment to a community resource contact, which means they look for a community resource to get a hold of that may benefit them. And they also make a new commitment to homework that's linked to that session topic. Seeking Safety sessions run about 90 minutes. Each group member is encouraged to share. They're definitely not forced to share. They are always told they have an option to just listen. which can be very helpful as well. With the Seeking Safety treatment, there are 25 session topics. I'll give you an example of a few of the topics. One that is conducted in the beginning of treatment is called PTSD, Taking Back Your Power. Detaching from emotional pain is another. When substances control you. Asking for help. Community resources. Self-nurturing, and safety is another topic. And we'll look at the safety topic in just a minute. Okay, on to safety. Safety itself appears to be the first and most important stage of recovery from PTSD and substance abuse. Victims of domestic violence are also supported and encouraged to consider safety as the first step to change. The Seeking Safety treatment session titled Safety has been beneficial in helping group members with any combination of PTSD or substance abuse. And I just want to make the point that victims of domestic violence may or may not have PTSD. So these Seeking Safety groups really are helpful. So looking at the safety group session topic, in this session, members are able to define what safety means to them. The message of personal safety, use of community resources, and self-care and self-nurturing are main points in the safety group topic. Some of the safe coping skills that are learned in the safety group are very powerful, and a lot of our women use them and continue to use them even after they're out of our program. Some of these safe coping skills are compassion, which would mean listening to yourself with respect and care in regards to the PTSD or substance abuse. Create a buffer, which is putting something between you and danger, putting something between you and danger like time or distance. Another is reach for community resources. Lean on them. They can be a source of great support. And so that's examples of a little bit of the safety group and the safe coping skills that come out of that group and that are continue to be used. So moving on to support services, with our family drug treatment parents, we're able to provide groups for nurturing parenting. It's learning healthy, nurturing parenting skills. We also have on-site mental health therapy and calm services, which is an additional component which provides parenting services for the parent and the child. Also, a relapse prevention group called Matrix is offered. We have on-site child care. We provide case management. And we also have residential treatment programs when outpatient isn't enough. So let's say we have a woman who was referred to us from Family Drug Treatment Court. She's in our outpatient program, and she didn't maybe divulge any kind of domestic violence issues, but as she's been coming to our program and in the group, she starts getting comfortable and she starts talking and opening up about domestic violence. If it seems like she may be in danger with where she's living, like if she's living with the perpetrator, we can help assess that situation, talk to all the agencies involved on her case, and offer her a residential program where it's safe for her, and that way of things working out has really proven to work well. The other way that support services happen is through community referrals, and those could be for financial services or even referring to the local domestic violence agency for some of their programs. As far as support gaps within this area and with this population, support gaps are inevitable, and they're always being considered as an opportunity to improve services. Communication, the way screenings are conducted, or the content of the screenings, those are always really great things to look at. And on the next slide, as promised, here is the information for contacting Seeking Safety, the website, www.seekingsafety.org. There's a lot of really great information on that website. And here's the contact information for Julie DeFranco and myself. I would love to hear of any questions or anything regarding the webinar. So that is it for me. Thank you very much.
Thank you so much, Julie. That was some wonderful information. And we did receive a question during your piece, and I wanted to ask you if you could speak a little bit to who participates in the Seeking Safety group. Is it the domestic violence victims, the participants in family and drug treatment court, or both?
It's anyone can attend. I'm sorry, give me just a second. We run our domestic or Seeking Safety groups weekly for all clients that are in our program. The clients in our program are all women, but we do have Seeking Safety in some of our other programs where there's co-ed attendance. Seeking Safety isn't ran here for our domestic violence parents. It's just an add-in. It's a support. I just want to make clear we don't provide domestic violence services. This is just kind of an extra support and help with safe coping skills.
Okay, great. Thank you so much for that. And then also, Julie DeFranco, during your piece of the presentation, we received a couple questions, and I wanted to see if you can talk a little bit to if you have any difficulties finding providers to serve clients who have demonstrated mental health needs.
Right. That's a very good question, and the answer to that is twofold. The first piece is that yes, I think many of us are challenged with access to timely mental health services. We're fortunate in our county that we have a network provider list, and many of whom are well-versed and skilled in attending to issues of interpartner violence and DV, but it is an area of continued struggle. With that said, under CAM, we've actually been able to dedicate 2 clinicians to serving our FDTC population, and that has been of great benefit to us in rapidly accessing those services and having a very close collaboration. So I hope that answers that question.
Yeah, thank you so much. You know, we received a few questions in regards to how to support the parents in leaving the relationship, the domestic violence relationship. And so first I'd like to hear a little bit from Julie Borba, if you can talk a little bit to that. And then next, if Dr. Bennett, if you would mind to also have your perspective on that question as well.
Okay, so the question is, how do you support or guide a client who is leaving a domestic violence relationship? And first off, the struggle for those who are intervening and wanting to help a victim of domestic violence, whether it be a friend or whether it be someone in an agency helping a client, the first struggle is the expectation that the victim will quickly wake up to the reality of the situation and take immediate action. this expectation is there, especially if the abuse is extreme or if there's children involved. The average number of times a victim leaves and comes back to a domestic violence situation is 4 to 6. Domestic violence victims report that once a final decision is made to permanently leave, it's like they instinctively know they will not be returning back to the perpetrator. So basically, patience, understanding, and appropriate expectations are extremely valuable when helping and supporting a client who is trying to decide to leave a domestic violence situation. Dr. Bennett?
Yeah, I really agree with that, what Julie said. I think, first of all, it's always assumed that somebody wants to leave the situation if they're the victim of domestic violence, and in most cases that's not true. A lot of women want to stay in the relationship, they just don't want to be battered. So they look to the court to fix this. A lot of the courts also have the opinion that once battering occurs that the next logical thing is to leave. But that's not what the victim wants. So this is where sometimes the court and therapists and other people are at odds with the victims of domestic violence because they can't understand why they don't do what everybody else would do if they were in that situation. Of course, everybody else wouldn't do that if they were in that situation because they would be seeing it from the inside rather than the outside. Make no mistake about it, the absolute worst thing that you can do to a victim of domestic violence, and something that you should never do, is to tell them to leave. That's not your business. That's not your job. Your job is to support and empower the victims of domestic violence to make decisions. Your job is not to say what the decision should be. If the decision is that she wants to remain in the relationship and find a way of coping and surviving, then that's your business, is to help them do that. Keep in mind, there's a lot of things worse in this world than being the victim of domestic violence. Lots of things. Being dead is worse. Losing your kids is worse. Being out on the street is worse. In fact, the time when people are at the greatest risk for domestic violence is after they leave the relationship. So the worst thing you tell them is leave the relationship. That's like saying, well, how'd you like to really get the snot beat out of you for a change? Just leave. And so my point is that be supportive of what they want to do and let them make the decision. We should always assume that battered women know best. I saw a lot of questions in the registration stuff about women in denial of domestic violence and how to get them to do what they're supposed to do. No, that's not what we do. That's not our job. Our job is to be supportive and help them make a decision, knowing that they are the people who will make the best decisions. They're the people, and this is supported by lots of research. Battered women make the best decisions, and they have the ability to best predict the lethality and the danger that they're in, far better than psychologists and therapists and judges and all of those sorts of people. So, bottom line, be supportive, find out what they want to do, and help them do that. And don't use the word denial, ever.
That's really interesting. You say that, Larry, Dr. Bennett. The next question that we received is in regards to that is what is an appropriate way to question if there is DV in the relationship, but they are in denial?
Well, some of the questions that I gave you from the web are very helpful in that regard because it doesn't confront the person about being in denial. It basically asks, and it doesn't really ask them for how often are you getting beaten and all of that sort of stuff. It goes to the heart of the matter, which is how do you feel in the situation. It goes all sort of Dr. Phil on them. How's that working for you? You know, how does it feel living your life in the house under the situation that you're in? What's that like? Are you afraid? Do you walk on eggs? Blah, blah, blah. You can kind of go down the list. Help the person to talk about those situations from the way it feels with no idea, and don't think of that as denial. Think of it as a kind of a peeling the onion thing. They're gradually learning to accurately figure out where they're at in their life and understand the situation that they're in. And I think we respect that, but we ask them questions which will help them think more fully about the situation. So that's the way I would do it. I would just abandon all notion of trying to get people to do what you think they need to do, because you don't know. what they need to do.
Great, thank you, Larry. And I was wondering if either of the Julies or Teresa, if they have anything that they would like to say in response to that question as well.
Well, this is Julie DeFranco, and I would just appreciate both responses previously. And from a child welfare perspective, there's also the added reality that families need to make their children and safety of the children and safety in the home a priority. And so without being punitive or threatening, we really work to support parents in understanding the importance of their safety as it relates to parenting and having their children return to their care. And so that's kind of a hard line and a message to have to present, but it's the reality of what families are dealing with. And so I think it's the combination of the therapeutic services that are provided through our community partners and the Seeking Safety program in combination with kind of a consistent as supporting and nurturing as we can message that essentially you need to know that your children can't come home until you're ready and able to take this step.
Julie, thank you so much for your response to that question. And I just want to, we're kind of running low on time, but we want to have some time for some resources. So I want to let you know that if you did submit a question, and of course you can submit a question anytime up to the end of the webinar, or you can email us any other questions you may have. But if you did submit one and we did not respond to it, we will be posting all questions and answers on the FDC blog. So if you didn't get your answer today, you will get your answer by the presenters on the Family Drug Court blog, hopefully in the next few days by the end of the week. So I'd like to go ahead and turn it over to Teresa Lemus, who is going to bring you through some next steps and resources.
All right, thank you, Alexis, and thank you to our presenters. Those are some great points, and it's often a challenge to think about all of the different balls that we're juggling with these cases, but I think even really stresses the importance of what we're going to talk about next, which is really working in a collaborative manner so that we can help the family make the next best choice that they see is in their best interest. So where do we go from here? How is responding to domestic violence a collaborative practice issue? I think we've underscored that point, and one of the things, because we are targeting this to family treatment drug courts, one of the things that I promised that we would talk about is if you haven't made the first step, really looking at the structure of your family drug court. And so if you look at this slide, it's a little bit busy, but if you just look over here on the left-hand side at the FDC structure, and then you just take that straight across horizontally, you have an oversight, an advisory committee, a steering committee, and then you have your actual family drug court team. And, one of the first steps may be to look around in the community, identify, who is providing services or who is an advocate for services for domestic violence. Bring that person onto your oversight or steering committee to start talking about where do we go from here. I think you're going to hear some examples of family treatment courts that are doing some of this, and I think that if you look at the systems level, particularly oversight and steering committees, this provides your team an opportunity to really think about, what are the implications if we start to ask these questions. As Larry said earlier, what do we need to have in place first? Because you need to think through those issues, and having that person on your committee to bring that expertise is definitely going to be in your best interest. If we look then at responding to domestic violence at the case level, and that's really at your core team that meets together every week and staffs cases and is doing the work hands-on with the families, that's where you want to have the actual screening in place, actually asking those questions, whether that be at the treatment agency, child welfare, or with your other partners that come to the table. Some family treatment drug courts have done this work. They've sort of laid the foundation, and they actually have a domestic violence advocate at the table. And so we're going to give you, tell you about those sites so that if you have specific questions, you can let us know and we can put you in contact with them. So again, additional things and your kind of checklist for, where do we go from here is A, looking around in your community and talking about who's available to talk with your family drug court team at that upper level. Who can you engage in the process so that you can start that dialogue? I mean, remember that when you first started your family drug court, it was a challenge to just get child welfare, substance abuse treatment, and the court on the same page. So I'm not saying, we're not saying it's going to be easy to incorporate domestic violence because we all have a different idea of who's our client, but it is very possible and it's a conversation that you need to have. Is there a way to co-locate DV advocates? Is there a way to have them eventually on your FDC team? Have you developed those cross-system protocols and partnerships? Dr. Bennett and both of Julie's, I think, really stressed the importance of warm handoffs, meaning that, it's not a slip of paper and here, go call, this person. It's actually ensuring, walking them to, making sure that they actually get where they need to go when it comes to this issue. And let's not forget that there's children involved, and I think we've stressed that, but we also need to think about the services to children and that how are we addressing their needs in the cases that they have been traumatized and we have them in our care. Cross-training. I was at a very large conference with domestic violence advocates primarily last year, and I was kind of surprised, very, very happily surprised that they were just as concerned about how to work with us as we are with them. And so they're trying to find a common language with us and vice versa. So I think it's a really good time for us to take that next step and reach out to them. And you can go on to the next slide. You'll have that slide in your packet and both of these actually to talk to you about or to provide you to some different places that you can go for resources and documents as well as funding. And again, some of the resources that we've talked about and we've referred to in this webinar are here for you to look at. I promised that we talk a little bit about the, some of the family drug courts that have incorporated this work. Through the Office of OJJDP, there are some family drug courts who are peer learning courts and are in what we call the PLC program. And they're courts that, family drug courts that really, in some cases, have taken the next steps on many issues, but in particular, some of them have made some strides in dealing with the domestic violence population, making sure that they're addressing this population. And I don't have time to go through all of them, but I'll give you an example in Georgia, the Chatham County, Georgia site. They actually have a domestic violence advocate liaison who sits on the operational team, attends staffing and court hearings. And so they are sort of the eyes and ears and help the team determine whether or not, we need to do something or we need to take a next step with this family. The other courts that are listed here all, again, have taken a next step in that they have partnerships, active partnerships with the domestic violence community and either have someone sitting on that steering committee or are at that staffing level and ensure that those warm handoffs are occurring. So if you have questions for any of these courts or of us to help pair you up with someone who you think you might want to talk to, please let us know. Our next slide talks about our FDC Learning Academy blog, and this is a place where if you have additional questions, you want to post information about what your site is doing and you want to interact with folks on our blog, it's listed here at www.familydrugcourts.blogspot.com. So we encourage you to get involved with that so you can exchange ideas and information. And finally, I'm almost done. We would really like for you to consider registering now for our next webinar, which is Passing the Judicial Baton, Why Succession Planning Matters in a Family Drug Court. So those of you sitting out there smiling right now thinking, yeah, we've been through that, you know that anytime there's turnover in your team, if it's not well planned for, it can be sort of a jolt to everyone. So we've put together a team, a panel to talk to you about how passing the baton in different roles on the Family Drug Court is possible and can make a big difference. So that webinar is coming up in April on the 10th from 10 a.m. to 12 p.m. Pacific time. And with that, I'd like to thank you. I'd like to thank all of our presenters. If you have questions for any of us, our contact information is located on the PowerPoints. And we hope that you found today's webinar valuable and helpful. And we'd love to see you attend again. So until then, take care and have a great day.